So this year at ASH, our group has presented two abstracts on a topic that we think is very interesting from the point of view of the translational impact. And this is the role of the gut microbiota in patients receiving CAR T-cell immunotherapy. And so we have one abstract that was presented by Dr. Andrea Facciabene as an oral presentation at ASH, and is more focused on the preclinical modeling of the role of the gut microbiota in CAR T-cell immunotherapy, and a more clinical abstract that is a collaboration with the Memorial Sloan Kettering Cancer Center that was presented by Dr. Melody Smith, again, as an oral presentation. So the two abstracts focus on the same topic. In other words, what is the role of the bacteria that patients have in their gut, and how those bacteria in the gut can affect the outcomes of CAR T-cell immunotherapy. Recent work in the last, let's say, 5 years have shown that the bacteria in the gut can actually affect the outcomes of another type of immunotherapy that is called checkpoint immunotherapy. And so we wanted to ask the same question in the setting of CAR T-cells. And so starting with the preclinical abstract, in that work, we use a model of lymphoma in mice, and we treated those mice with CAR T-cells. And we modulate the composition of the bacteria in the gut using an antibiotic. As you know, antibiotics can affect the survival of bacteria. That's why they're used for infections. And so by giving an antibiotic that is called vancomycin, that is specifically active on gram-positive bacteria and is not absorbed. So if we give it orally to mice, it's just going to influence the bacteria in the gut and it doesn't have a systemic effect. What we noticed with the group of Dr. Andrea Facciabene is that the mice that were receiving CAR T-cell immunotherapy plus this antibiotic called vancomycin were actually having a higher antitumor effect as compared to the mice that were receiving the immunotherapy alone, indicating the modulation of the gut microbiota might affect the outcome. And interestingly, what we've seen is that it looks like the mechanism by which this antibiotic enhances the effect of CAR T-cell therapy is that basically increases the number of antigens that the CAR T-cell can recognize in cancer cells. So not only through the CAR-specific antigen, that could be, for example, CD19, but also through the T-cell receptor that can recognize other antigens that are expressed in the cancer cell. And so this preclinical work obviously is interesting, but of course we wanted to have a sense of what happened in actual patients. And so with the group at Memorial Sloan Kettering, we analyzed two cohorts of patients. One cohort was a retrospective cohort of patients with acute lymphoblastic leukemia and with non-Hodgkin lymphoma. These were all patients receiving CAR-19 immunotherapy. So either 4-1BB co-stimulated CAR-19 or CD28 co-stimulated CAR-19 in clinical trials and in the commercial setting. And so in these patients, we look at the antibiotic use in the 4 weeks before CAR T-cell infusion. And the question was, can the use of these antibiotics in the 4 weeks before CAR infusion affect the outcomes of CAR T-cells? And it was very interesting because when we look at the antibiotic use, first of all, we saw that over 70% of patients were receiving some sort of antibiotic. So this means that these patients really have a strong need for antibiotics before CAR-19 therapy. But most interestingly, I think, is that exposure to any antibiotic. So if you look at patient receiving any antibiotic versus patient receiving no antibiotic, actually patient receiving antibiotics had a poorer outcome. So they had a poorer progression-free survival, poorer overall survival. And in particular, when we look at the different types of antibiotics, there was a group of antibiotics that we call PIM, P-I-M. This is piperacillin tazobactam, imipenem, and meropenem. These are broad-spectrum antibiotics with a specific activity on anaerobe that in the past have been shown to be really affecting the gut microbiota. And so those antibiotics that we call PIM were very much associated with poor outcomes. So low progression-free survival, low overall survival in both acute lymphoblastic leukemia and lymphoma. And interestingly, in patients with non-Hodgkin lymphoma, we also saw increased neurotoxicity. So this is one of the common side effects of CAR T-cell. And so this was the first cohort that, of course, is retrospective, but was sort of suggesting that the dysfunctional microbiota, it can be associated with different outcomes. And of course, we also ran multivariate analysis to make sure that the groups receiving antibiotic and not receiving antibiotic was actually comparable. The second cohort, it was a much smaller cohort. The first cohort was about 200 patients. The second cohort, 50 patients, about 50 patients, is a prospective cohort where we collected the stools at baseline, and we analyzed the gut microbiota in there using 16S sequencing or shotgun metagenomics. And interestingly, what we saw is that, first of all, patients receiving CAR T-cell therapy have different composition of the gut microbiota as compared to healthy individuals. This can be due by the disease, this can be due for the treatments and many reasons. But most importantly, that we found specific taxa of bacteria that were associated with different outcomes. For example, we saw the rumidococcus was actually associated with a higher complete response in patients receiving CAR T-cell therapy. And we also identified many other genera of bacteria that can potentially be associated with better outcomes. There were also other strains of bacteria that were linked with the presence of toxicity. And so again, this is just to underline the fact that modulation of the gut microbiota, that could be either voluntary, if you use specific antibiotic or probiotic or prebiotics and so on, or just happens because of the treatments and so on, can actually have an effect on the outcomes of CAR T-cell immunotherapy. So obviously these studies sort of show, I think for the first time, that is the case, but we will need to have larger studies to identify for sure what are the specific strains, if any, that are associated with differential outcome, or if just the diversity that is affecting these outcomes. And once we learn more about that, we can really start crafting potentially treatments. So either using antibiotics before CAR T-cell or during, or modulating with fecal material transfer and so on. And so this is the work that we presented at ASH. And again, I want to stress this is collaboration between my group, the big group at Penn that is headed by Karjun, the laboratory of Dr. Facciabene at Penn, and for the clinical part, the collaboration with Dr. Marcel van der Brink at Memorial Sloan Kettering, and Dr. Melody Smith, who is now a assistant professor at Stanford. What we need to do next is to expand our cohort of patients for whom we have the stool samples to analyze. And we're actually doing that in collaboration with a larger multi-center group. And not only looking at the stool samples at baseline, but we also want to see over time how the microbiota evolves during CAR T-cell therapy. And of course, once we learn more about the mechanism, so what are the taxa, the genera that are involved, the diversity, and so on, we can look more at the mechanism. And once we identify more data on the mechanism, also using preclinical models, we can design a potential treatment, a potential strategy to modulate the gut microbiota in CAR T-cell patients.